Hello, I'm Dr. Gudi. I'm a consultant in reproductive medicine and assisted conception at the Homerton Fertility Center. This is Andreas, as we know, a very skillful surgeon, endoscopic surgeon, as well as a very skillful surgeon in endometriosis and fibroid surgery, and Dr. Kulkarni, who is an IVF specialist in India and who does a huge amount of research in polycystic ovarian disease. Today's discussion is having a brief idea about how we deal with fibroids and infertility, and we're taking a general opinion of what we do. So let's have a look at the diagram. Fibroids that are in the myometrium, number 4. Fibroids that are 50% or more in the endometrium, number 1. Fibroids that just touch the endometrium and bulge into the endometrium, number 2. Those that touch the endometrium but have no bulge, and the other large fibroids which extend through the entire structure of the uterus. This is what we'll be discussing, and we'll put this picture across in the talk. So, Andreas and Sachin, if we look at the fibroids, we see them very frequently. They are challenging. Surgery can either cure or can make things worse with adhesions and other factors. And what I want to know is, what would you do? Let's talk of fibroid 1 and 2, one that goes entirely into the cavity, and number 2, which dips into the cavity. And this is a woman who has infertility. What would you do with these fibroids?
Clearly, being infertile, you want to increase the chance of succeeding in pregnancy. So, as we know, this type of fibroids can compromise fertility by increasing the risk of miscarriage. Therefore, the indication to operate in these fibroids is there. Now, as a surgeon, you have to choose the best way where you're going to give the best outcome, and the best outcome will be with the minimum distraction to give the best treatment. And therefore, fibroid number 1, where most of it lies within the cavity, there's no doubt that resecting it either with a resectoscope or with a moscillation, if it's doable, that will be the approach through hysteroscopy. Now, with regards to 2, again, as long as you can see part within the cavity, you could proceed with hysteroscopic approach, and then more with resection, where your skill will get you down to the root of the fibroid and make sure you make sure that you take all the fibroid out and not leaving anything behind. So these 2 we will approach with hysteroscopy. Now,
the other thing is, I will, for many people who do hysteroscopic surgery, one of the things which restricts our skill is many of us stop at the level of the endometrium. And what you're saying is that you may need to scoop in and resect further in, to try and get to the capsule of the fibroid. Is that what you mean?
Correct, because the fibroid is there, and you know if you leave it there, it will carry on to give you a problem. Whether it's small or big, it is a problem. So you need to have the expertise to go just behind the capsule and dig down without distracting any endometrium, and dig down into the myometrium and take out all the fibroid tissue.
Would you do a laparoscopy at the same time? Would you not worry that while resecting the fibroid, as you go into the myometrium, that you may get very close to the serosa and you may end up perforating?
Well, this is an important point, because this is where the ultrasound scanning comes forward prior to the surgery. So I do scan these patients, and I know exactly how much tissue is left behind the fibroid. So if I have a worry that I might breach or come close to the serosa, to me, this is an indication to go laparoscopically rather than go hysteroscopically with a laparoscopic guidance. Otherwise, if through my ultrasound I know that this fibroid can be attacked hysteroscopically without any danger into the serosa and further on the other organs, then I just go straight with hysteroscopy.
What would you do, Sachin?
I do agree upon him, and there are 2 methods which have been described scientifically. One is called a Hamu maneuver, wherein you withdraw the hysteroscope, do a little vigorous bimanual examination after doing the partial resection of the fibroid hysteroscopically, so that whatever remaining element is in the myometrium gets pushed down, and then again go back with the hysteroscope and try and remove. Second is you use a cold loop. With the cold loop, you just press on one side of the fibroid, so you try to scoop it out from the other and try to keep removing, so that you are continuously using a diathermy in the cavity. It remains little restricted, and you can have less injuries and less touching all the way to the serosa. I think that a submucous fibroid will require a surgery is undoubtedly, I think it will be a universal consensus. One would go with that. The question is going to be the non-cavity distorting intramural fibroids. Now, should we be operating the non-cavity distorting intramural fibroids?
Which is number 4. But before going to number 4, I want to point out something which Andreas says is very important, is in many parts of the world, gynecologists do not scan as part of their training. It happens in India, it happens across in parts of Europe, but in Central Europe, there is, during your residency, people learn to scan alongside their clinics. And what Andreas says is so important is, as a surgeon, that assessment of a patient is ideally done by the surgeon themselves, where you do an ultrasound scan, check if there is beyond the base of the fibroid. Is it 2 centimeters? Is it 1 centimeter? Is it half a centimeter? Leaving it to someone who is not going to operate is risky, and that restricts the quality of surgery a surgeon can offer when he cannot do an ultrasound scan.
Yeah, even in India, I would say most of the endoscopic surgeons, especially before doing a hysteroscopic surgery like this, do prefer doing their own sonographies before the patient goes onto the table for the surgery, because they really want to get their first-hand look at the myometrium available to them to do the surgery. No doubt about it. That's so true.
That's what we call the fibroid mapping. And especially we have multiple fibroids, and whether you will undertake hysteroscopy jointly with the laparoscopy, you might well have scanned the patient before and talked to her, but actually the morning of surgery I take the scan machine in theatre and I scan.
I was just going to come to that. Do you do an intraoperative sonography at the time of hysteroscopy?
Many times it's there, and depends my memory and my pictures, but many times it doesn't take long, even with hysteroscopy, a probe in the abdomen or transrectally, to know exactly where you are. But a patient comes to you and she wants to have one good surgery, full stop. Therefore, use all your tools before you undertake surgery. So even in the morning, she's got 4 or 5 fibroids, all of them have to come out. If your decision is to make surgery, you might well take all out. And therefore, mapping the fibroids prior to your surgery is crucial, and therefore I completely emphasize and agree that knowing your ultrasound as a surgeon, I think it's a must from 2018 onwards.
Now, what do you do with fibroids that, like number 3, which are 3 to 4 centimeters, not very large, which just touch the endometrial cavity, they do not distort the endometrial cavity? What would you do?
Actually, till date, there was a lot of confusion about managing these fibroids which are in the intramural and not distorting the endometrial cavity. But after publication of a systematic review by Sunkara et al., where they have done about 6,057 cases they looked into, and they said, removal of these fibroids definitely improves the pregnancy rate, number 1. And I would say intramural fibroid is a little misnomer. We need to subclassify the intramural fibroids into a fibroid which is very near the junctional zone and the fibroid in the outer. So we need to subclassify them into junctional zone fibroids and outer myometrial fibroids. The outer myometrial fibroids, you can just leave them alone. They wouldn't interfere with your fertility. But a junctional zone fibroid, even if it is touching the junctional zone, that definitely needs a removal. And a study which has just been published maybe 2-3 months back, it has been published only on the type 3, it's a retrospective analysis of the type 3 fibroid, and they have removed those type 3 fibroids, and they find, the implantation rates do improve. So as we stand today, we can definitely say that if there is intramural fibroid, more commonly the junction zone fibroid, and if the fibroid diameter is beyond 2 centimeter, or the sum of the fibroids, multiple fibroid diameter is beyond 2 centimeter, well, the removal does improve the implantation rate. But my problem starts now that we are seeing an intramural fibroid, which is not seen hysteroscopically, which is not seen laparoscopically. It's seen only on ultrasound. And how do I go in with laparoscope in? How do I see? Where do I take my incision? And how do I go about this surgery?
So what do you do, Andreas?
It's the mapping again. So many times, once the decision is there to proceed with surgery, I know exactly through my ultrasound, and I mark a centimeter down, a centimeter left, make a cut, you're going to hit the fibroid.
Okay.
It's very rare, once you know you're scanning well, that you're going to fail. And you make a very small incision. Once you see the fibroid tissue, you know it's there, and then you proceed further. And fibroids like these, it's very important that you minimize the destruction to the endometrium. So I wouldn't think twice to go in laparoscopically and remove it rather than go through resecting endometrium and then get into the fibroid.
So 3 onwards, we will definitely go laparoscopically, so as to preserve the endometrium to its best
Absolutely,
function.
and also it gives you the opportunity to assess other things, tubes, endometriosis. So you've got this huge opportunity to have a look into your pelvis, and therefore I think it's more advantageous than doing hysteroscopy. But I listened to everything you said about evidence, and it's absolutely brilliant that you bring this up, and we know how evidence and how we should follow evidence. But let me put it from a different angle, that in everyday practice, we cannot use evidence all the time, and it's more individualizing the case. And for example, we have a number 3 fibroid there, which is probably 1/20th of the endometrial surface that is touching. I might well leave it alone.
Yeah, definitely.
Because she has a huge possibility of implanting embryo elsewhere.
You're perfect. We have to look at it very holistically. And probably you will leave it alone. But let's say the same patient has had 2 IVF failures. Probably you may have to just go in and
even to that I have my input to say, and I take this from many examples. When people send to me poor responders, 44-year-old woman who wants to get pregnant, remove the fibroid and then we'll do an IVF. Well, no, make embryo first. And then I'll do an operation, because this fibroid is asymptomatic. So if I go and give her surgery, she pays. She went through surgery and all the risks. We don't know if we've got embryos. So do the embryo and then proceed.
The other thing which I have often seen, and I think we have covered even stage 4, my intramural fibroid not touching, and we covered that. I have seen in a few cases that prophylactically, even without removal of fibroids that do not come into the cavity, there are clinicians who give 3 courses of long-acting analog to reduce the size of the fibroids. I can't find evidence that it improves implantation if it's not involving the cavity. Would you give a long down regulation before your IVF if a fibroid does not involve the cavity?
No.
I've never done this, because if it's big enough, I'll go laparoscopically, where I don't need the GnRH analogs because I lose my planes. No, I don't find this useful.
No role of doing something like this. Absolutely, it will be just waste of time and money.
As a fertility specialist, my concern always again goes in that in poor responders and older women, you reduce antral follicle count with prolonged down regulation, and your success rates may tend to vary and your response may vary. The last type of fibroid, which I have a different opinion about it, and my concern, are large fibroids. And they are fibroids that touch the endometrial cavity, and they go across the entire myometrium and come subserous. So I call it a global fibroid. It's my term. There's no such term as
transmural.
Absolutely. What do you do with these fibroids? There are 2 parts of this question. One is that, do you remove them, and how do you remove them? Number 2 is, how do you repair them? Because I have a very interesting story which I'll come to later. What is your opinion, Andreas?
I think in an infertile woman who has big fibroids getting closer to the cavity, most of the times you will end up removing them than not removing them, because usually these ones contribute with other symptoms as well. And also we have to remember this woman will get pregnant, the fibroid will get bigger, there is a risk of necrosis, there is a risk of compression symptoms. So I think case-to-case discussion, most of the times they will end up having surgery to have their fibroids removed. And I don't know your view on this, but
yeah, we would go for surgery, but definitely again, like endometriosis, we need a good expert surgeon to do this myomectomy, because suturing, proper suturing and approximation of the tissues and restoring the normal anatomy is going to be so vital, rather than creating a sinus there inside.
We know we can take it out. Now, I have had 2 cases of women who had a 5 or 6 centimeter fibroid, which took the entire space, and it was fundal, and it was removed and sutured laparoscopically, and both of them had spontaneous uterine rupture at 34 weeks without contractions. I can understand with contractions. Now, my concern is, I'm not an obstetrician, but my concern is that when you have the entire length of the fibroid, are our suturing techniques compromised by laparoscopic surgery, or do you still do 2 or 3 layers of suturing with laparoscopic surgery? And what would you do in this case? Because these fibroids worry me when you repair them.
Although it's a rare scenario where you have a uterine rupture prior to contractions. I have faced myself in the UK. Now, I think a bad healer is a bad healer. So regardless what technique you're going to use in certain uteruses, there are cases where the scar will be weak. Now, the thicker the wall, the defect of the wall, then the more layers you're going to end up doing. But I think through the suturing layer by layer, it can direct as to whether you're going to use 2 or 3. So layer is, as I said, it will tell you how many you need to do. Secondly, you need to ensure you have got good hemostasis by suturing and not by diathermizing it, because putting a diathermy there, you destroy the tissue, therefore your healing process is worse, therefore the risk of rupturing is higher. Then the other thing we have to remember is that we need to reconstruct the uterus correctly. And I've seen videos when patients came to me and brought some DVDs from their surgery, and I just close my eyes. I just see one suture going around, and you can tell as a laparoscopic surgeon, this patient shouldn't even suture. Why they undertake such an operation? And you compare this with a skilled surgeon who you can see how beautifully and elegant the suturing is, and therefore the healing is better. So we come back to what we discussed before. Who does the suturing? It's crucial. And finally, once you complete the surgery, you need to ensure when the patient needs to get pregnant. And I don't think there is huge evidence about this. Most of people say 4 to 6 months and then you can get pregnant. But again, there are so many different cases. So yes, in some ones you might say, yeah, 4 months is enough. Some others you need a little bit more. You need to follow them up and see. It depends where the fibroid it was, how you undertook the surgery, and so forth. So again, individualizing each case by an expert.
Absolutely. I think individualizing is so very important, because we commonly see fibroids, but we commonly see women getting unassisted pregnancy with fibroids.
Yeah.
That's also a very common scenario for most of our obstetric practitioners. So I feel we really have to have more studies and more evidence also generated about which fibroids really need a surgery, and they would make a difference when it comes to the pregnancy outcomes and the fertility outcomes. And we're definitely looking for some good trials being conducted for all those things. But till date, whatever evidence says that a submucous fibroid or intramural fibroid which is beyond 4 centimeters is something which we will definitely be surgically tackled for the future.
So in short, I think we've got a brief idea about what we do with fibroids. Again, thank you very much, and hopefully we'll put more of these videos up later. Thank you.
Thank you.